Hello, my name is Michael Luvera, and I'm a consultant pharmacist licensed in the state of Florida. I'm currently a first-year fellow at UF Health Physicians. And along with my co-fellow, Dr. Jay Choi and Dr. Taylor Burr, we aim to work alongside the Buchholz PTSA to inform the community on opioids, naloxone, and medication safety. This presentation is the third part of our series. I'd like to take a moment to welcome those of you back who joined one of our previous presentations. Our first being an overview presented to the PTSA, and the second where we virtually joined the science classrooms. Today, with part 3, we hope to bring it all together. After this presentation, our goal is that you have developed a background on the opioid epidemic, have a basic understanding of opioids, identifying an overdose, the importance of naloxone, and where to find additional resources. This presentation ended up being a bit longer than we anticipated, about 45 minutes in total, so I'll include timestamps to specific sections you may be interested in. I'll start off by giving you a brief background of the opioid epidemic, explain opioids, naloxone, look into stigma regarding opioids, mention some of the legal protections that exist in Florida, and lastly, I'll list some additional programs and resources. Looking back at my notes, I realized that we may have missed answering some of the questions that you all have asked. So if there's anything you felt like we didn't cover, or if you filled out the feedback forms that we left at the previous presentations and we never got back to answering your question, I'll make sure to add those towards the end. But before I dive in, I just want to disclaim that recreational drug use covered in this presentation may be a sensitive subject for some viewers, and neither I nor my colleagues have any affiliations with any manufacturers of the medications presented. And with that out of the way, starting with the opioid epidemic, how did we get here? Opioid epidemic is often broken up into 3 distinct waves, which we'll discuss in a bit more detail. The first wave was marked by an increase in deaths from many commonly prescribed opioids. The 1960s saw increased attention from the medical community in addressing pain management. In 1977, the World Health Organization, or WHO, added opioids to their first list of essential medications, which are drugs that are, essential. They believe the medicines listed should be made available by health systems at all times. Later, a study published in the New England Journal of Medicine, one of the most prestigious medical journals, reported that only 4 out of about 12,000 patients who were prescribed opioids in the hospital went on to develop an addiction. These eye-catching results led to many lectures on the benefits and safety of opioids across the country. In 1986, the Cancer Pain Relief and Active Supportive Care Expert Committee of WHO introduced the Pain Ladder, a treatment escalation plan for pain related to cancer. In 2001, the Joint Commission, the accrediting body which sets standards for many health organizations, abbreviated here as TJC, set a standard declaring that patients have a right to pain relief. As the movement to cure pain picked up steam, the number of opioid prescriptions in the US increased. Here you can see the original WHO Pain Ladder as a graphic on the left. For reasons we'll discuss later, this was later amended to the process on the right, which includes surgical options and an increased emphasis on deprescribing, or proceeding back down the treatment ladder by removing medications if the patient can tolerate it. To better understand the second wave, I'd like to familiarize you all with the term diversion. This is the illegal distribution or abuse of prescription drugs or their use for purposes not intended by the prescriber. While the second wave was characterized by increased use of heroin, this was, at least in part, caused by diversion by both patients and medical professionals. Diversion led to dependence on opioids, and from 2005 to 2015, the proportion of opioid users who started with heroin, as opposed to prescription or other opioids, quadrupled. Shortly following the rise in heroin use, the third wave of the opioid epidemic saw an increase in the use of synthetic opioids. This was driven by increased demand, and advances in science allowed for the creation of stronger synthetic drugs. Some even describe a fourth wave as an increase in the number of stimulant overdoses, and overdoses with various combinations of medications have been seen. To better address the opioid epidemic, policymakers and prescribers have shifted their approach to opioids. There is an abundance of caution when opioids are indicated or clearly needed by patients. Prescribers may fear being sued, worry about their patient's safety, or have underlying unconscious bias towards opioid use. This means they may view opioid use and opioid users negatively without even realizing it. Limits to the amounts of opioids that may be prescribed have been strictly enforced. There are limits to the number of days for which opioids are legally allowed to be prescribed, depending on the type of pain the patient is experiencing. There are restrictions on who may prescribe opioids, and they have to register with the Drug Enforcement Agency, or DEA. Prescription drug monitoring programs allow prescribers and pharmacies to track patients' use of certain medications with additional risk of harm if not taken as prescribed. The PDMP in Florida is known as eForce, which shares information with all other 47 contiguous states. Additionally, professional organizations have developed guidelines to recommend pain treatments, including dosages, how to handle switching medications, and non-opioid, non-drug treatments. Healthcare workers are encouraged to set clear goals and realistic expectations for patients experiencing pain. Rather than totally eliminating pain, the emphasis is now on reducing or managing pain so that patients may return to their daily activities. Although there may still be some discomfort, the goal is always to use the lowest dose and duration of medication possible without causing unnecessary harm due to untreated illness. Finally, there has been increased concentration on chronic opioid prescriptions limited to pain specialists. Now, you may be asking yourself, why is this topic so important? You may have heard of the opioid epidemic, but you may not personally know of others experiencing these issues. So let's take a look at data taken from over 22,000 surveys conducted at 235 public and private schools from February to June of last year. As you can see, 0.4% or fewer students reported heroin use within the 12 months prior to taking the survey. 2.4% of high school seniors reported using other narcotics without doctor supervision. Medications like OxyContin and Vicodin were each reported as being used in less than 1% of 10th and 12th graders. Now, all these statistics are near historical lows, but as you may recall from earlier, the landscape of the opioid epidemic has shifted to increased overdoses of synthetic opioids and combinations of drugs. Comparing those surveys to slightly older data on overdose deaths due to any drug in 14 to 18-year-olds, we can see there has been a large increase from 2019 to the first half of 2021. Some have blamed social isolation due to school closures and stay-at-home orders during the COVID-19 pandemic, additional psychological stress, financial strain, and lack of access to treatments for substance use disorders as potential causes for this increase. Because the data on deaths lags behind the data on self-reported opioid use, it's hard to tell if the trend will match the near historic lows of reported use, or if it's continued to increase since 2021. Regardless, from June 2020 to June 2021, 26 deaths have resulted from heroin overdose, 66 deaths occurred from prescription opioid overdose, and an alarming 884 teenagers between the ages of 14 to 18 years of age have died in the US from synthetic opioid overdose. This Venn diagram from 2022 shows which opioids, aside from illegally produced synthetic drugs, adolescents 12 years of age and older misused. This is just meant to really hammer home the fact that heroin use in teens has been decreasing, but there are still areas for improvement. This chart helps answer the question, where are teens getting these drugs? It's important to note that this is limited to prescription painkillers only. If you take a look, a vast majority of prescription opioids come from friends, family, and healthcare providers. Most are coming from legitimate prescriptions written either to the person using them or from a loved one. And honestly, a lot of times it's not even for the purpose of getting high or using them recreationally. Sometimes people have the intention to help a loved one in pain without fully understanding the risks. We'll discuss misuse a little bit later, but it's basically using medications differently than they're prescribed. This is just my quick PSA to check any brightly colored labels on your prescriptions. Stickers like the one you see here are placed on most opioid prescription bottles. This reminder is meant to make sure the patient is aware that they shouldn't be giving their medications to others. Other labels or stickers can have an important note on side effects or how to take the medication. Here I have a couple images showing the scale of lethal doses of opioids if ingested. This one is from New Hampshire State Police, shows heroin and fentanyl in little vials next to a ruler, so you can see they're about 2 inches tall each. This one from the Maryland Department of Justice includes carfentanil here on the left. This is a potent synthetic opioid mainly used for large animals. The penny, in my opinion, really helps with the visualization, but just to get an idea of the mass, we're talking about the average monarch butterfly weighs about 500 milligrams, and ants are typically between 1 and 5 milligrams. So although these lethal doses seem small, and they are compared to everyday objects, I'd like to point out that fentanyl, when used therapeutically, is dosed in micrograms, so in increments of thousandths of a milligram per day. Now that we have a little background on the opioid epidemic, what are opioids and how do they work? The words opiate and opioid are often used interchangeably, but in the case of opiates, which are derived from opium, a chemical from the opium poppy, which you can see here on the right, this nice detailed drawing from the 19th century here. And on the other hand, we have synthetic chemicals, in which case they would technically be classified as opioids or opium-like substances. We typically associate these chemicals with reducing pain among a bunch of other effects. These are just a few examples of opiates: morphine and codeine, which are commonly prescribed for severe pain, and heroin. Now that we've learned the term synthetic opioid is a little redundant since opioids are synthetic by definition, here you have a few common examples. So you may be surprised to see things like NyQuil, Robitussin, and Imodium on the list. While they are opioids, at therapeutic doses, they typically don't cause the same effects seen with opioid painkillers. And in the case of Robitussin specifically, the active chemical that prevents cough works in a totally different way than other opioids. Here are a few more examples of opioids you may have seen before. Starting on the left, we have oxycodone pills, 2 different dosages here. Next is Actique, which is a lozenge or basically a tiny lollipop with fentanyl, which honestly looks a lot more like a Q-tip in my opinion. And then over-the-counter examples I mentioned previously. Most of the examples we just looked at are used for analgesia, the scientific term for pain relief, or anesthesia, which is the loss of sensations, although we usually only think of this as going under for a surgery. I'll spend the next few minutes briefly explaining how opioids work. Whenever you experience injury or pain, there are a number of complex biological processes occurring in your body. There are even different types of pain, but we'll focus on pain that starts with damage to a tissue or group of similar cells in the body. In this example, a bee sting results in damage to the skin and supporting structures. Nearby pain receptors, called nociceptors, are activated, sending a pain signal up the nerves of the spinal cord all the way to the brain. The signal can be amplified or inhibited on its way to the brain, allowing you to experience pain and hopefully avoid whatever is causing it. Now, aside from medicinal and recreational opioids, there are also naturally occurring opioids in your body called endogenous opioids. An example you may have heard of are endorphins, named for endogenous, meaning produced internally, and morphine. These help dull the pain response. Now, you may be familiar with this process if you've ever been under heavy stress and not noticed an injury until much later when things have calmed down. Your body essentially interrupts the pain when it realizes, okay, since you probably know you should avoid whatever just caused that, hopefully you can run or fight back without being limited by pain. Opioids used for pain bind to some of the same receptors as endogenous opioids and have a similar effect. These opioid receptors exist in many different parts of your body. Here, I have a really basic model. The large orange U-shaped structure represents the opioid receptor, and the blue oval represents an opioid molecule. The opioid will bind to the receptor, and after a number of reactions, it produces a noticeable effect. Medicinally, obviously, we want this to relieve pain. Common side effects of opioids include tiredness, nausea and vomiting, constipation, and slow, shallow breathing. As a quick note, there are different types of opioid receptors with varying effects all over the body. This is part of the reason why we can have some over-the-counter opioids that are intended to cause constipation or relieve diarrhea in the case of Imodium or loperamide, for example. As mentioned, opioids target a specific receptor to relieve pain. At higher doses or the use of stronger opioids, side effects are more likely to occur due to activation of more receptors as well as other receptors. One of these includes activating the reward center of the brain. Other chemicals are released in the brain, resulting in intense pleasant feelings or euphoria. If you recall earlier, I mentioned healthcare teams should set clear expectations of pain relief and explain that some discomfort may persist. At opioid doses that are too high, the line between eliminating pain and causing pleasure are blurred, which can play a role in addiction. Now, in an overdose, opioids will slow natural breathing, leading to less oxygen in the body. The person may even stop breathing altogether, and this is the main danger of an opioid overdose. And that brings us to our next section, recognizing an overdose. These are the most common signs of an opioid overdose. Clammy, cold, and pale to blue skin, lips, and nails, due to these areas not being supplied enough oxygen. Pinpoint pupils, a slow heartbeat, and slow, irregular breathing, or breathing that is totally stopped. The person experiencing an overdose could also be choking, or you might hear them making a gurgling sound. The person may not be able to respond when you talk to them or tap them on the shoulder. They may lose consciousness, keep falling asleep, or have a limp body. A solution for an emergency situation involving opioids is naloxone. Naloxone is a medication that can reverse an opioid overdose. It blocks the effects of opioids on the brain with the goal of restoring breathing. If we look back at the model we used to explain opioids, we can get a better sense of what naloxone is doing. As a reminder, the opioid molecule binds to the opioid receptor, causing a number of effects. In an overdose situation, many of the receptors are being activated, and one of the effects is slowed or stopped breathing, meaning less oxygen in the body, which can be deadly. Naloxone reverses the effects by competing for that same receptor, but in this case, without activating it. For this reason, naloxone can help restore breathing. And if the person hasn't taken any opioids, naloxone really isn't going to affect them. Here we have a few examples of naloxone products. We have the intranasal formulations, which you are likely more familiar with. Narcan and Cloxato are two common brands that come in these winged nasal spray devices. There's also a generic atomizer where a vial of liquid is pressed, pushing the medication through the tip to create a mist. We also have an injectable formulation. These are sometimes used by emergency responders. The example shown here is Zimhi, spelled Z-I-M-H-I, which is an auto-injector similar to how an EpiPen is given. We'll go over how to use the nasal formulations, since they are currently more widely available and affordable. You can even get them for free in many cases. For this walkthrough, we'll assume you've already seen a couple signs of an overdose and called 911. Maybe you see someone who looks like their lips have turned blue or gray, and they don't look up at you when you call their name and tap them on the shoulder. So you think they might be experiencing an opioid overdose. You immediately call 911 to send help, and you let them know you'll administer naloxone. First, you're going to lay the person on their back. Next, you'll remove the Narcan from its packaging, which comes in a little plastic carton with paper backing. When you hold the device, rest your thumb on the plunger and place your index and middle fingers on either side of the nozzle on these little wings that you can see in figure number 3. When you're ready to administer Narcan, you should tilt the person's head back, supporting their neck with your free hand. Then, you'll gently insert the tip of the nozzle into one of their nostrils. Either one, doesn't matter. And you're going to want to make sure it's inserted so that your 2 fingers touch the bottom of the person's nose. This helps make sure the medication gets to where it needs to go and that you give them the full dose. Now that everything is properly set up, you'll press the plunger firmly with your thumb to administer the dose. Remove the device and stay with the person until help arrives. Hopefully, you've stayed on the line with 911 and they've either almost arrived or already arrived. But if 2 to 3 minutes goes by and the person doesn't seem to be getting any better, they don't wake up and respond, or they're still not breathing correctly, you can administer a second dose if you have one. Typically, 2 doses come per box with Narcan. Before my mic died, I was hoping to give you all a closer look at my Narcan. So here I'm trying to be as elegant as possible, showing the paper and foil backing, the instruction booklet that comes with it, and then you can see the winged sides on here where you can hold the device. I like that this one has a red plunger, and then here I'm just trying to demonstrate that your fingers should be touching the bottom of the person's nostrils. Here's the lot number and expiration date, which is important for a lot of medications, just to keep track of these things, especially if there's a recall. Next, we'll take a look at the nasal atomizer. In a similar situation, after recognizing a possible overdose and calling 911, you'll open the syringe, which has caps on both ends. In our example, there are 2 yellow caps on either end of the syringe. Next, you'll take off the cap of the naloxone vial, which is red in our example. The atomizer nozzle will also need to be screwed onto the syringe. It has these little wings to help with grip in this step. The final preparation step is to screw the vial of naloxone onto the barrel of the syringe, which will pierce the vial. The tip will be placed into one of the nostrils and be administered with a firm press on the back of the vial. The device will be loaded with 2 doses, so half of the vial should be used for the initial dose, with the remainder used as the second dose if needed. So now that we know how to use naloxone, this is how it fits into the bigger picture. If you don't remember anything else on responding to an overdose, the most important steps are calling 911 and administering naloxone if it's available. Some instructions say to give naloxone first and then call 911, but either way, these are going to be the 2 most crucial steps to preventing death in the case of an overdose. Outside of that, you should try to keep the person awake and breathing if they improve after naloxone. Try to lay them down on their side into this position that we described earlier to prevent choking in case they vomit. Stay with the person until emergency assistance arrives. And finally, give a second dose if they remain unresponsive or continue to have trouble breathing after 2 to 3 minutes. Medical attention is still necessary even if they seem to be improving. Since intranasal naloxone has a short duration, they will need to be medically monitored. They may need several additional doses, since some opioids may persist in the body from several hours to days. In our next section, we'll discuss drug culture and stigma. Stigma, or the negative feeling towards a person or group of people based on certain perceived characteristics, can be harmful. You may have heard of stigma in the context of mental health, socioeconomic status, or the use of alcohol and other drugs. This can lead to increased stress, lower self-esteem, and avoidance of resources, so both people and helpful tools. While many understand the issue of stigma, it can be difficult to address since it has multiple levels and even more causes. At the macro or systems level, the laws, regulations, and policies that govern us can create barriers and make it more difficult to receive care. Negative sentiments are often echoed in policy and media, which may further propagate stigma and ingrain it into a system's foundation. In relation to opioid use, healthcare professionals can perpetuate stigma through treatment decisions at the meso or public level. If we choose to treat one group of people and not another, either consciously or subconsciously, so without even actively or purposefully doing it, it may seem like the first group deserves treatment, help, and compassion, whereas the other is undeserving of our help. Finally, at the micro or individual level, stigma or the perception of being stigmatized by others affects care. As with the previous example, if an individual feels judged, hopeless, or that they're undeserving of care, they may hide their issues from friends, family, or doctors. Furthermore, experiencing stigma has been associated with delays in getting care, withdrawing from treatment programs, withholding information or giving the right answer. So, if your dentist asks, "How often do you floss?" and you instantly reply, "Every day," even though it's only happening once a week, that's kind of what I mean. Sometimes people will give the ideal answer for fear of judgment, and then their health team doesn't have the full picture needed to help them. Interestingly enough, stigma has also been associated with an increase in risky behavior and avoiding naloxone and any labels that might come along with carrying naloxone. Hopefully, you've gained a better understanding of why stigma is harmful, and in our case, has the potential to worsen the opioid epidemic. But how do we address the issue of stigma? First, we can try to avoid stigmatizing language, so words like addict, junkie, or referring to someone's status of recovery as clean or dirty. Ideally, we would even try to push this in the opposite direction. Instead of simply avoiding stigmatizing language, we could make an effort to use destigmatizing language, especially in our policies. For example, we would use the appropriate medical diagnosis of opioid use disorder to counsel an individual rather than label them an addict. Next is something that you're all doing by watching this video, so thank you all for that, which is trying to gain a better understanding of opioid use disorder, reversal agents, and treatments. Even though we won't cover long-term treatments, we'll include some resources to help get access to these. Since stigma is associated with perceptions, we could try to gain more knowledge on a subject before forming a thoughtful opinion. Think about your first impression of someone if you find out they've abused drugs or if they carry naloxone, and try to reflect on why you think or feel that way. Next, improving access to care and removing barriers to treatments and medications to prevent withdrawal can curb avoidance behaviors by normalizing seeking help. Our last strategy is having universal naloxone, which is something that has honestly seen great strides in recent years. Here are a couple ways you can help or learn more. September is National Recovery Month, part of a campaign from the Substance Abuse and Mental Health Services Administration. You can join in their social media campaign or get informed as they try to promote evidence-based treatments and understanding of mental health and addiction. After a recent law, June 6th is designated as Revive Awareness Day in Florida, where we should see similar initiatives from the state government and their partners. And finally, we have lifeunitesus.com. The site aims to eliminate stigma in Pennsylvania, but you can attend webinars or watch videos of the inspirational stories of the everyday people who are affected by addiction. To springboard our previous coverage of stigma, we'll use this next section to define addiction and other related terms. Opioid use disorder, or OUD, is a recognized medical diagnosis that is sometimes used interchangeably with addiction. While addiction may be part of OUD, we'll take a deeper look at some of the associated terms and characteristics that contribute to addiction. Misuse is defined as taking medications differently than the provider has prescribed them. Medication or drug abuse is the misuse of a substance to the extent that it causes the individual difficulty. So it's essentially the next level of misuse. Let's say your doctor prescribes you morphine for a broken arm, and he or she tells you to take one pill every 4 to 6 hours if the pain is bothering you. If you take more than one pill at a time, or take it more frequently than every 4 hours because you feel the pain is unbearable, that would still technically be considered misuse. The appropriate path would be to notify the doctor how you're feeling, and they might adjust your dose or add some other non-opioid pain reliever. Now, if the one pill did help you with your pain, but you decide to take a couple more anyway just because you like the way it feels, this would be considered misuse as well. But if you start feeling some mental fog and having trouble in school or at work, now it would be at the level where it's considered abuse. Tolerance, which can occur over the course of treatment or as the result of misuse, is the need to increase a drug's dose over time to produce the same biological effect. Similarly, taking the same dose of a drug that starts to have less of an effect over time is also considered tolerance. Again, I should stress the fact that tolerance can occur over the course of a typical treatment and is expected with many medications. Although it is often associated with addiction, tolerance can develop through a few different processes by which your body tries to achieve homeostasis, or your body's own natural baseline. Substance or chemical dependence is a cluster of cognitive, behavioral, and physiological symptoms, so changes to your thoughts, moods, attitudes, and how you physically feel, that can cause continued use of the substance despite the presence of significant issues. It includes a persistent pattern of repeated use leading to an intense internal drive to continue using the substance, tolerance to its effects, and withdrawal symptoms once the substance is cleared from the body. Dependence encompasses the terms we covered previously. It includes misuse and abuse since the medication or substance is causing noticeable issues. It may cause physical symptoms, including some unpleasant to downright miserable symptoms once stopped. For opioid withdrawal, this includes flu-like symptoms, nausea, vomiting, diarrhea, racing heartbeat, agitation or anxiety, and trouble sleeping. Since we define tolerance as needing more of a substance to have the same effect, withdrawal occurs with increased tolerance to the point where not taking the substance basically causes the opposite effect. That brings us to addiction, which is the dependence on the use of a substance, activities, or behaviors. Finally, we can tie everything together to define opioid use disorder. It is a problematic and recurrent pattern of opioid use characterized by tolerance, withdrawal, craving, and persistent use despite failure to fulfill role obligations, and other problems resulting from opioid use. OUD has some specific criteria to make a formal diagnosis, but this provides a solid working definition to paint a better picture of the condition. Some of the factors associated with higher risk of developing opioid use disorder include younger age and male sex. There are genetic factors, including family history of addiction. A history of sexual abuse has also been associated with increased risk of OUD, as well as some psychiatric conditions, including anxiety, depression, and post-traumatic stress disorders. Now that we have a foundational knowledge of opioids and the opioid epidemic, I will mention some of the laws and regulations regarding opioids. And since I'm obviously not a lawyer, I'll try to limit this to a very high-level overview. The U.S. Drug Enforcement Agency, the DEA, has the authority to schedule or place medications and chemicals into categories based on their risks of abuse and for dependence. Specifically, medications that are placed into Schedules 1 through 5 generally have decreasing risk of abuse and or dependence. These are known as controlled substances. Starting with Schedule 1, these drugs are considered by the DEA to have no acceptable medical use. Heroin is an example of a Schedule 1 drug. Other controlled substances, beginning with Schedule 2, have the potential to be abused or cause dependence, but they may be prescribed by a physician or other health practitioner when under their supervision. These controlled substances have specific requirements before they can be prescribed by a provider or dispensed by a pharmacy. This can include requirements for medical exams before receiving the prescription. Ideally, information regarding a patient's health care would be provided to them all the time, but when prescribing controlled substances, it is often specifically mandated. There may be legal requirements to verify identification, so when filling these prescriptions, The pharmacy may be required to review the patient's government-issued ID. There are also limits on the amounts of controlled substances that a patient may be prescribed. The limit depends on the type of medication, the condition it is meant to treat, and specific to opioids for pain, the limit varies based on the type of pain. So whether it's related to a recent injury or surgery, or if it's used for pain related to a chronic condition or cancer. Apart from the requirements for healthcare professionals, some states, including Florida, have passed laws to expand the availability of naloxone. I'll include some resources in the next few slides, but the push for universal naloxone is really driven to prevent the numerous deaths associated with opioid overdose. Many states also have similar Good Samaritan laws, which offer certain protections to those seeking medical attention for overdoses. I briefly touched on this in the section on stigma, but 2 laws regarding opioids were recently passed in Florida. Victoria's law and Senate Bill 718 were signed by Governor DeSantis on April 8, 2024. Victoria's law designates June 6th as Revive Awareness Day to encourage the Department of Health and its partners to hold events to raise awareness of opioid overdose and naloxone. Senate Bill 718 amends the Florida Comprehensive Drug Abuse Prevention and Control Act. This law will go into effect on October 1st, 2024. It relates to the use of fentanyl and fentanyl analogs by adults and essentially criminalizes certain situations where first responders are harmed due to exposure to these drugs. Now, the second law has been criticized by some healthcare professionals who believe it perpetuates a myth that touching fentanyl can kill you. Exposure was defined in this law to include absorption through the skin. As far as I'm aware, there have been no documented fentanyl overdose deaths caused by touching fentanyl pills or loose powder. There is a fentanyl transdermal patch that has been specifically formulated to assist the drug to be absorbed through the skin, but it's designed to release small amounts of the medication over the course of 3 days. Even some of our more potent synthetic fentanyl analogs require large amounts of skin contact or several hours of contact to allow an appreciable amount of drug to cross through the skin. Theoretically, someone could create a new opioid that absorbs through the skin more quickly, but it would be difficult to say the least. Your body has plenty of barriers and proteins that shuttle things out of where they're not supposed to be. Drugs also have to avoid getting deactivated or destroyed by the body. So while theoretically this may be possible at some point, to summarize, brief external exposures to fentanyl are unlikely to cause serious harm based on our current knowledge. And I sincerely hope no one would be discouraged from calling for help for someone experiencing an overdose. I'll finish up by providing some resources for more tools and information. Here are some quick resources promoted by the Department of Children and Families. You can scan any of these QR codes if you're interested and navigate to these sites a bit faster. They're helpful if you or someone you know needs treatment or help with substance use, mental health conditions, or finding naloxone. These are some other sources of information, including naloxone training from the CDC, reports on adolescent drug use, which I used for this presentation, so that's going to be your third link, and a toolkit to help prevent and respond to overdoses, so some help with emergency preparation. Finally, we have the Treatment and Program Directory of the Department of Health. isavefl.com has information and places to get naloxone in Florida, but if you're unable to access any of those sites, nextdistro.org is able to coordinate naloxone delivery by mail totally free of charge. This is actually the site that I personally use to have my Narcan shipped to my house. Lastly, we have DEA Drug Takeback. Drug Takeback Day is a national event that occurred most recently on April 27th, 2024. But not to worry, Drug Takeback Day happens twice a year, and you can also use the website linked here to find the locations closest to you that will accept and dispose of your unused or unneeded controlled medications year-round. I want to emphasize that this is the preferred method of disposal. But the Food and Drug Administration also maintains a flush list of certain high-risk, controlled medications that can be flushed down the toilet as a last resort. This is somewhat controversial, but FDA considers the benefit of eliminating access to potential misuse of these medications to outweigh the potential negative impact on the sewage system and the environment. Disposal is really important when it comes to opioids. If you recall from the opening section, a vast majority of misused prescription pain relievers are obtained through a personal prescription or from a friend or relative. There are also a number of initiatives being rolled out so that you may be able to mail those medications to be destroyed or be supplied a container to take home that will deactivate the medication. Lastly, I want to thank you for your attention and participation in this initiative. I know this presentation was packed full of information, but just in case you're interested, here are the resources I referenced to put this presentation together. I always encourage patients to do their own research, so please feel free to fact check me if anything I said was surprising to you. So someone suggested that we cover doctor shopping. This can have a few different definitions, but in the context of opioids, this basically means that a patient will go to multiple providers in an attempt to get multiple prescriptions. So this is one of the targets of the prescription drug monitoring programs, the PDMPs. But these also depend on healthcare professionals doing our part. So taking the time to do the proper research, enter information in the system, and so forth. So there might be some lag time if multiple visits are scheduled in a very short amount of time. So, on the same day within just a few hours. But I believe Florida has a law that makes doctor shopping in this context illegal. I believe this comment is in response to me saying that opioids like morphine are fairly potent or relatively potent. I can definitely appreciate the intent of this comment because obviously the opioid epidemic is a very serious subject and many people have died as a result. So just to explain a bit further what I meant originally, in the medical context, potency is often just thought of as strength of a chemical or drug. Sometimes we think that a more potent drug may be more risky or that it works better. Really, it just means the amount or concentration of a substance or drug needed to have a specific response. And this response doesn't necessarily have to be the intended treatment effect. It can be complex, but in our example of a drug binding to a receptor or its target and having an effect, higher potency can mean less of an opioid is needed to relieve pain or to cause euphoria or to stop breathing, just as a few examples. Potency is affected by how strongly the drug molecule is attracted to its receptor, known as affinity. But it's also affected by how strongly the effect in the body is produced once the drug and the receptor bind. So just to say it in a different way, two drugs can have the same affinity, but one might be better at activating a certain receptor. So naloxone, which we call an opioid receptor antagonist, has an affinity or an attraction to opioid receptors, but doesn't create the same effects as opioid receptor agonists. So things like oxycodone, like fentanyl. So basically, if you took a certain amount of morphine and the same amount of fentanyl, the fentanyl is much more likely to cause the effects that we expect from opioids. And price of naloxone. So I mentioned earlier some of the resources that distribute naloxone for free. Additionally, most insurances will cover naloxone if it's prescribed. There have also been initiatives from prescribers to include naloxone prescriptions along with opioid prescriptions as a safety measure. But if you're paying out of pocket, each nasal spray typically costs about $50. And that's for the prescription version. So I actually just pulled this up from my local Walgreens. So the goal for the over-the-counter version, which you see here, meaning it can be purchased without a prescription, is under $50 for a 2-pack. But again, there are many programs to try and distribute naloxone for free. So I recommend isavefl.com and nextdistro.org. I'll make sure to include links to those. But if you go out of state, many state health departments, I should say, also have programs to get it for free or for low cost. And And lastly, during one of the previous presentations, there was a question about naloxone and its effect when someone may have used fentanyl or other synthetic drugs. So I went back to double check afterwards, and depending on the study that I looked at, it kind of varies slightly. So I think previously I said that naloxone is or has a higher affinity than fentanyl, but a better answer that I can give is that the affinity, so again, the attraction of a drug molecule to, an opioid receptor in this case, is pretty similar between naloxone and fentanyl. So some resources that I was reading say that slightly more, has a slightly higher affinity for opioid receptors, some that it was slightly less, but overall it's pretty similar. So the good news is that naloxone will still compete with synthetic opioids for a spot at the receptor. So that little cartoon model that we used before. But obviously naloxone won't have any effect. And so kind of like what I mentioned a few slides ago regarding potency, even if a drug is more attracted to opioid receptors, we can overcome this with larger doses of naloxone. So this actually is a great final point to help emphasize why calling 911 and getting that emergency medical attention is so crucial for someone experiencing an overdose. And obviously naloxone is only going to be able to counteract the effects of opioids and not other medications or other drugs, which are becoming a lot more common, unfortunately.